Welcome, friends, to Faith in Healthcare, where we continue to explore the issues that matter most to Christian healthcare professionals. So whether you're in healthcare, married or otherwise connected to someone who is, or you're just simply interested in how God is working through Christ followers in patient care and beyond, we're so glad that you're here. In this episode, I'm joined once again by Dr. Steve Willing. Steve is a radiologist with more than 40 years of experience and now serves at Children's of Alabama, specializing in pediatric neuroradiology. Alongside his medical work, he teaches apologetics at Regent University, is also part of the scholar community at Reasons to Believe, and he recently graduated as a Colson Fellow. He's also the author of a book that I had a nice discussion with him about last year called Superbia, The Perils of Pride, the Power of Humility. Today we're going to tackle one of the most complex and controversial issues in healthcare, especially in the West and in the U.S., what is described as a transgender identity through the lens of neuroscience. From brain imaging studies to neuroplasticity and the effects of puberty blockers, Steve brings clarity, humility, and evidence to a conversation that has left many healthcare professionals, including some who hold a Christian worldview, searching for real truth. Most importantly, Steve encourages us as Christ followers in medicine to approach this issue with courage and compassion as well as conviction. So let's dive in. Well, today on Faith in Healthcare, our new moniker for this weekly program, I've invited an old friend. This is his second time on the podcast, Dr. Steve Willing, whom I met a number of years ago in southwest Kenya at Tenwek Hospital. Steve, among a long list of other accolades and degrees and things that he has done in his life, has been a part of a very vital group of radiologists who've read studies, CT scans in particular. I don't think you've read any MRIs yet for Tenwek Hospital, have you, Dr. Steve?
Well, we don't officially dictate them, I'd have to think, but we certainly are called to look at them from time to time because they get scanned elsewhere and then they can get uploaded.
So we've had a lot of technical conversations in the past about things, interpreting x-rays and doing distance image reading. But little did we know that we would ever be having a conversation on faith in healthcare about a topic that, when we met, was not on our radars, was it?
No, God always can surprise us.
Well, Dr. Steve Willing received his medical degree from the Medical College of Georgia, followed by an internship in pediatrics, something that I had forgotten about, Steve, from the University of Virginia, residency in diagnostic radiology at the Medical College of Georgia, followed by a fellowship in neuroradiology at the University of Alabama at Birmingham, and went on to get his MBA as well. Very much involved in academic medicine, Steve. But more recently, having kind of pulled away from full-time neuroradiology, I've heard you interviewed in a couple of programs, and you said, what I care about most now is apologetics, and I believe you're a visiting fellow for Reasons to Believe, are you not?
The technical term is visiting scholar. They have a large scholar community where the people who are like-minded evangelicals with a commitment to sort of an old earth interpretation of Genesis and defense, skepticism of evolution and defense of the creation model kind of team up. But there are a wide range of disciplines being represented, including a fair representation of physicians among that. And that's actually what got us started in there, because about 3 years ago, perhaps, the board of RTB suggested that the RTB community get more involved in sexual issues, and they decided, this transgender thing might be a good one to dig into because it was so timely. And so we were commissioned, a team of 4 physicians plus theologians and philosophers were commissioned to develop a white paper to research the literature and to come up with a position paper on how to approach the issue from a Christian and biblical and scientific standpoint. And that's what led to this whole thing. Out of that, they assembled a panel for the Evangelical Theological Society meeting in San Diego in November of last year, of which I was one of the representatives, and I was asked to speak on the subject. And I decided the best thing was to stay in my lane and
Sure.
stick to my area of expertise, which is neuroscience. So I decided there's probably a few people who are any more qualified than myself to address the data emerging on the neuroimaging of transgender brains.
So you
So
wrote.
that's how.
So at the end of December, you wrote an article, Transgenderism Through the Lens of Neuroscience, and 2025 has been about you on various platforms explaining this whole issue of neuroscience and how it relates to addressing this issue, which has left so many of those with a biblical worldview and male and female, as described in Genesis, very frustrated, as well as those who are even not biblically, not from a biblical perspective, but very much evidence-based and not ideologically driven. But let's start with the basics here, because you do in your article and in your talks and interviews that you've done, you do start with basics, like what in the world is transgenderism?
Yeah, I invoked that term transgenderism for the title of my talk, and pretty soon I found that some people actually object to anybody using the term because they said, well, they think that this just casts transgenderism as an ideology when they think it's a real medical condition. Well, the suffix ism can mean many things, okay? It can mean an ideology like Marxism or atheism, or it can mean personality traits like racism or altruism, or it can mean a condition or state, which is how I interpret it, like autism or hyperthyroidism. So for purposes of my talk, I'm just saying it's simply the state of being transgender. I'm trying not to make any representations as to whether there's merit to it or not. And it turns out that I'm not alone. To check myself, I searched for the word transgenderism on Google Scholar, and over 30,000 scientific citations appear that employ the term. So it's widely used. It's not an ideological taking sides kind of thing.
And Steve, most of us, I think, would look at the whole issue of transgenderism and the whole topic of gender identity and think you're either for it or you're against it, as they say. And you point out that you may be for it, but lots of different perspectives on it, with gender affirmation, and you may be gender critical, as you call it, and have different perspectives within that realm. So why don't you unpack that for our listeners?
Yeah, for the purposes of my approach, I first tried to divide the camps into two sides. The one that I call gender affirming, and those who would support gender affirming care in some context, or gender critical, and I would say those who would probably be skeptical of gender affirming care in any context. But those are not homogeneous groups on either side. On the gender affirming side, you might have uh, a camp that still thinks it might be a mental illness. That was the mainstream position up until 2013 when the DSM-5 was released, that recast it sort of as a normal variant in the absence of dysphoria. But that doesn't mean because they changed the DSM that everybody in the mental health community is on board.
Mm-hmm.
So there could be, and probably are, still some clinicians who still think it's a mental illness, but would support gender transitioning in certain circumstances. That's one group. The second would be the one that's wholesale on board with the changes in DSM-5, and therefore they think, say, a man identifying as a woman could be a perfectly normal variant of human biology and development, and in the absence of dysphoria, it does not represent a mental illness of any sort, simply the spectrum of normal human development. But there's still a third camp. They don't all agree. There's a third camp. This would be more of the philosophers like Judith Butler and Michel Foucault. Judith Butler and this crowd were arguing decades ago that all gender differences were socially constructed. There's no biological basis to male-female differences. And Therefore, the transgender is just the second song of this second verse of the same song. It's still, of course, it's all socially constructed, but hooray, let's celebrate it. Let's go on with the transitioning. So that's the affirming side. And then on the gender critical side, there might be different viewpoints. I mean, one, it's just a delusion, like somebody who thinks the earth is flat, somebody just believing something that's false. Second, again, there could be people pre-DSM-5. They still think it's a mental illness, but they would be skeptical towards any transitioning in any case. Um, the third case situation would be it's just a social contagion. It's kids imitating other kids, and this kind of thing happens. And then maybe the fourth would be this expressive individualism that Carl Trueman wrote about. And in that case, it's a person kind of trying to define their own reality. Interestingly, that's really consistent with what Judith Butler would say. I mean, Carl Trueman would say, yes, this is socially constructed. The only difference between him and the Butler camp would be that those on this side would be very skeptical or critical of gender transitioning. So everybody doesn't agree. There are different ways of framing it, and therefore different ways, different hypotheses to be tested.
Okay. Well, let's get to the core part of your expertise. Since we have a medical healthcare audience that's listening in or watching, having a pretty good understanding of what neuroscience is. So talk to us about neuroscience and this issue of transgender identity. Even using the term transgenderism, for me, our ethics committee at CMDA, which has been in existence for many, many years, came up with a wonderful statement that I've heard you refer to in other interviews, and did not even call it transgenderism, but transgender identification, to try to stay away from that word itself. But how does neuroscience help us with this whole topic, which has led to so much confusion, so much controversy, and so much tension within the healthcare community?
There are different ways that neuroscience addresses this. The most salient, I guess the most immediately obvious, addresses one of the gender affirming positions that I took, that this is a normal variant. In this camp, the person, say arbitrarily, a man who identifies as a woman, would argue that he really may have the body of a man, but he has the brain of a woman. Now, I could be accused of misrepresenting their position, but that position has been explicitly stated. I would start seeing in the literature that people would invoke neuroimaging literature saying that research shows that if we look at their brains, they more align with their gender identity than with their birth sex. What also emerges when I actually look up those references, they say the opposite. So I decided, okay, this is an area where I have some expertise. They're relying upon structural imaging of the brain, which is MRI, just looking at the cross-sectional anatomy, and functional imaging of the brain using more sophisticated techniques, looking at activation of brain regions and brain networks. And so, as it turns out, there have been a lot of studies that have been done in the last 5 years attempting to tease out this hypothesis that the trans woman has the brain of a woman, not a male brain that she was born with.
Steve, help some of us who maybe when we went through our training years, there were no functional MRI studies, and I've heard you describe assumptions that are made about blood flow, oxygen delivery, and so forth, and what that means about what's happening in the brain. Are all these assumptions pretty much accepted as gospel truth across neuroscience, for neuroradiologists, or are some of them fairly soft and maybe not as solid as you'd like them to be in coming to some of the conclusions about the male brain and the female brain?
Well, the short answer is I don't have a huge issue with the methodologies, but let me explain how these are acquired. You can't put somebody in an MRI scan and directly look at activity within the brain. You're talking about transmission of electronic potentials along neurons and axons, and trans synapses, and this cannot be directly imaged. What we have is an indirect measure. Usually it's using blood flow because hemoglobin has iron in it, which has magnetic properties. If you have more blood flow, you have more blood. You have different ways of assessing blood flow. So we have an indirect measure. The hypothesis, therefore, is that if certain brain regions are more active, metabolically, they demand more blood flow, and that's reflected in increased blood flow on MRI. So that's the kind of plain English explanation of how this is done. And then there are two ways of doing this. One is just resting. They call it steady state functional MRI or resting state functional MRI. The second is then ask people to do tasks like reading or listening or thinking about something in particular, and then looking for changes. And in theory, the regions that are involved in that task would show increased blood flow and therefore increased activity. But there's another step to that. It turns out these changes are so subtle, they're generally not immediately available to the naked eye, particularly if you're trying to evaluate results in a study group, a significant number of people. So then we have to take it another step and rely upon machine learning algorithms to tease out the differences and then determine whether they're statistically significant or not. So there are a lot of assumptions. Generally, there's not a reason to be skeptical of it, but all at the same time, because there are so many layers of complexity, it should always be interpreted with some degree of caution.
Steve, aside from the gender issue, even before that, uh, it has been concluded that male brains and female brains are different. Obviously, that's a very basic tenet here, understanding before we jump into the idea of whether someone's gender identity, whether an individual, a trans man, is more like a biological woman's brain or like a cisgender brain. So, settled science. I've heard you say it is settled science. Even in 2017, some statement by some guru in neuroscience that it's settled. Male brains are different from female brains. Is that correct?
Yeah, fair enough. As I said, this has been a matter of significant contention, particularly in the mid 20th century, coming out of philosophers like I alluded, Michel Foucault, Judith Butler, others. There was certainly a significant camp. They would fall in the category of second wave feminism, who wanted to argue that all male female differences we're talking about things like behaviors, emotional states, reactions, learning abilities, cultural roles, as it's all socially constructed. That if you take a little boy and give them dolls, and you take a little girl and give them trucks, they'll then develop along completely different trajectories. That it's all being sex determined by stereotypes imposed upon developing children. Well, there was an explosion of research. 1990s was designated the decade of the brain, and this was heavily researched. And like I said, like you said, in 2017, the journal Neuroscience Research came out with an entire issue containing dozens of articles explaining male-female brain differences. It was the editor who said this case is really settled. Larry Cahill wrote the opening editorial for that, and it continues to mass up. I'm always checking up, and lately I've been using ChatGPT a lot, ChatGPT, and I checked this morning and found out that there was a large study from Stanford that came out this year using functional brain networks, continuing to reaffirm this marked bimodal distribution, if not an absolute binary between male and female brains. Now, that doesn't mean that everybody considers it settled. There are always holdouts, okay? And most of them are sort of committed to second or third wave feminism and kind of motivated by an ideology.
So, Steve, where have we arrived in terms of conclusions then about brain structure and identity, gender identity?
Well, okay, there are two issues there. First is the identity based on biological sex. So if say a trans man, therefore born a woman, does he have a brain that corresponds to men, or does he have a brain that corresponds to females, which is how she was born? And we can actually test that. And then been a series of studies, and this is what I did in my paper. Um, I tried to look for all the relevant citations over the last 5 years, where they attempted to image the brains of transgender individuals using static or functional MRI and ascertain whether their brains more closely fit their birth sex or their identity. And as it turns out, in every case, they either completely aligned with their birth sex or they were much more closely aligned with their birth sex. I was unable to find any cases where they completely aligned with their identity. I was unable to find any cases where they more closely aligned with their identity. I found perhaps one or two that were kind of iffy, could go either way, or it was impossible to know from the paper whether they were more one way or the other. And that's one test. But you brought up identity, and that raises the other issue of where does identity develop in brain? And as it turns out, the identity development uses separate brain networks that are mostly independent of the regions that are influenced by sex hormones that therefore differ between men and women.
Fall is full of upcoming 2025 CMDA conferences. The 2025 Midwest Fall Conference is happening September 26th through 28th at the Maranatha Retreat Center on the shores of Lake Michigan. This gathering features speakers like Dr. Far Curlin, Dr. Stephen Coe, and a special panel with Dr. Carl Truman. You can earn up to 6 CME credits, and there's a full children's program for kids 12 and under, making it a wonderful weekend for individuals or the whole family. Join us for the 2025 Northeast Regional Retreat, October 24th through 26th at Sandy Cove Ministries in Northeast Maryland. This year's theme is Faith Embodied, led by Dr. Stephen Coe, a pediatrician and preventative medicine physician at Mass General Brigham in Boston. Continuing education credit is available. First-time attendees can also find an additional discount code on the event page. Learn more about all of these events and register at cmda.org/events.
Just for our listeners' benefit, Dr. Whelan, you gave a wonderful presentation just a couple of months ago for the ICMDA Thursday morning webinar, and I had a chance to watch that and to hear some of the wonderful questions that followed, and some concepts that came out of that I personally had never really thought about before. Given neuroplasticity, the whole idea of gender affirmation and hormones and what happens. Dr. Saunders, the CEO of CMDA, brought up the whole chicken versus the egg, and the whole idea of affirmation and how someone who would identify as transgender has gender dysphoria or incongruence, and the way they are treated. Now what happens with neural pathways and neural structures. And so your comments about the changes in the brain coming after affirmation and the way a social construct, if you will. So your comments and what you've read and learned in terms about how the brain responds to how many of these kids, and of course the numbers have been growing astronomically in the last 10 years for kids who have gender confusion, whether it's social contagion or dysphoria in the traditional sense. Talk to us about neuroplasticity and your thoughts, what you've read, studied in terms of brain changes, chicken or egg?
Well, I think John Locke talked about people being a blank slate, being born at birth, and an opposing view to that is that everything is deterministic and set at birth, and neither one of these really holds up. The idea of neuroplasticity refers to the fact that the brain is a very malleable organ. It's extremely adaptable, which can be a good thing and can be a bad thing, but the development is affected by its environment. chemical environment, hormonal environment, cultural environment, you name it. For example, the male-female differences, we know this is all very interesting and it could go on. If you look at some of the disorders of sexual development, say the congenital androgen resistance or congenital adrenal insufficiency in situations where, because of metabolic disorder or genetic disorders, males are feminized or females are masculinized. This also shows up in the brain, that the absence of androgens or estrogens acting upon the brain, their presence or absence affects the brain development. Another area where we see this, where they're showing this now, is there have been a number of studies now showing transgender people examining their brains after puberty blockers and after treatment with cross-sex hormones. And what they see as a result of the interventions, they're seeing the brains actually changed in the direction of their preferred gender and away from their birth sex. So we can manipulate that to a remarkable degree.
So what concerns do you have, and should our listeners, should Christ followers in healthcare and those who are evidence-based care deeply about long-term flourishing, in especially in kids, and you are continuing to serve as a pediatric neuroradiologist at Children's of Alabama, at least part-time, what, whether it's the CAS review alarming the world or other studies that have come about, what are the concerning things about affirmation, puberty blockers, cross-sex hormones in children and adolescents that have contributed to a screeching halt, whether it's UK or in Europe, nations that have been further ahead of us down this path of gender affirmative care?
Well, there are plenty of people, I think, including among CMDA members, who are more qualified than me to talk about the endocrinological aspects of this or the effects of puberty blockers and cross-sex hormones. But for me, I think for most people in this area, the guiding aspect is this historic principle in medicine of primum non nocere, above all, do no harm. And when we consider the situation of the gender affirmation, especially the medical affirmation, we know that there are harms. The harms are built in. I mean, if you delay puberty, well, it turns out that puberty is fairly critical for brain development. Again, neuroplasticity. If you stop puberty, you're going to alter the trajectory. The brain may have been going off one way and you suppress puberty and go off in a different direction. That's neuroplasticity. So there have been concerns raised about decreased IQ. Irreparable harm has been demonstrated in laboratory models using animals, using these puberty blockers, Lupron, and related drugs. And I already mentioned that administering the cross-sex hormones will alter the difference. So that's just on a neurological level. Of course, once you go to the medical route, there are also the attendant issues, which are a little about outside my field, but the reality that you're going to likely to lead to permanent infertility, a lifelong dependence upon medication, because you don't just put somebody on testosterone or estrogen for a couple of years. It's going to be for the rest of their lives. And of course, every drug, every treatment has risks. Okay, well, the risks are built in. So as with everything, we have to be respectful. Okay, what are the benefits? And that's the problem. That's why it kind of fails the CAS review and others who have looked at this. The benefits have been very elusive. Sweeping claims have been made. It's not, you can say there's no evidence. It's that they can cite papers, but when you actually dig into their evidence, it doesn't hold together. There's a lot of cherry picking. There's a lot of creative interpretations of the data. Extravagant claims. Particularly the most notorious one is suicide. Would you rather have a live son or a dead daughter? And that's sort of a terrorist approach psychologically to use on parents when the data in no way supports that. yes, this population is at increased risk of suicide, but no higher than depressed kids or kids with anxiety disorders. Mental illness in itself is a risk factor for suicide, but suicide rates among children remain way below suicide rates for adults. But more importantly, okay, if they think that's a valid argument, can you show that you've actually decreased the suicide rate? And in fact, no, they haven't shown no evidence of that. Uh, to me, one of the most damning evidences that has emerged, although it's not statistically significant, was in this case series of 300 coming out of UCLA Multi-Center Consortium led by Johanna Olson Kennedy. They had 2 suicides in their study group. There was no control group, but they had, out of 300, they had 2 suicides in the control group, one at 12 months and another at 24 months. Now, this is suicide in the people who are getting the treatment that's supposed to prevent suicide. So that particular element of the argument is probably the worst to invoke.
And certainly her hospital has subsequently, just in the last few months, shut down their gender clinic, as have a number of others. Keep getting people feeding me emails about yet another gender clinic that has shut down in the United States. My concern, Dr. Willing, is that while I believe that these are more likely related to political victories, not to clinical evidence and to a perspective within the House of Medicine having changed. I would love to be proven wrong and demonstrated and felt that I should change my perspective on that. Within your discipline, within radiology, specifically neuroscience, pediatrics, professionals that you hang out with and talk with, whether Christians or not, are you seeing any sort of winds of change in the perspective by healthcare professionals on this issue, which has been so ideologically driven for the last decade, if you will? Do you see any hope that healthcare professionals, by and large, are pushing back with clinical evidence, as you've shared a lot with us today, to give me hope, this CEO of CMDA, that even with political change in the future, that we'll still be heading in the right direction to protect children?
I'm afraid the pond I swim in is too slow to really address that on a community level. I mean, I'm in Alabama. It's a conservative state. I know it was going on. I don't think at Children's of Alabama. I think it was going on at UAB, just a couple blocks away. I'm not in direct contact with anybody. I've not heard anybody. It almost never gets discussed. Plus, we radiologists were, 10 hours a day pedal to the metal. So there's not a lot of socializing or chatting going on this subject. It rarely ever comes up. I think it would be really interesting to have a survey of a broader medical community, because like many, many things, this has been led by a very vocal minority of activists. And I share your concern and somewhat skepticism about a political solution to that. I mean, every time we see something, say, that we like and we applaud and say that's great, you have to do the counterintuitive thing. Okay, well, how would you feel if the opposing camp had that same degree of power and exercised it? Because you could have a change of administration, you could have somebody come in and mandate that every hospital in the country provide gender-affirming care. It would be nice that we had better ways of solving that. Those are generally my reflections. But we've had a good open discussion of it. I think it mostly has been civil and charitable. Yeah, there are always going to be a few belligerent souls out there, but I don't think outside the activist community the conversation on this subject has been particularly hostile. Now, I know we have had some people who've been persecuted for speaking up on this. You've addressed this in a prior podcast.
Yeah, and I would say that it really depends a little bit, as you've said, on your location and your specialty and whether or not you're in a community or academic setting. Because to this day, now granted, things are in flux. There's a delta happening right now, which as I believe is is a result of political winds of change. But in academic centers today in America, very few of our mental health professionals who are Christ followers feel comfortable saying much at all against the gender affirmation model. They've been silent. I've struggled to recruit and invite mental health professionals who follow Christ onto this program to talk about this. Very, very, very few. They are rare. Now, I'm hoping that will change, Dr. Willing, over time because of we're in a different time. But my feeling is that until the medical house, mental health professional house gets itself in order, that we're going to have difficulty convincing our professional societies. Very few of those. Maybe the American Society of Plastic Surgeons had the courage not long ago to make a statement that they were pushing back because of science against the gender affirmation model, but very few of the other mainline societies. So what encouragement would you give as we wrap this up? I don't think that you've experienced any fear or personal professional consequences from speaking on this topic, but for those who maybe are weighing the pros and cons of speaking up in their local fora, professionally in their community, what encouragement would you give to them working with other physicians at Reasons to Believe, doing apologetics? What would you share? What words of affirmation, encouragement to your brothers and sisters in Christ?
Well, humility is always a good approach because you're probably less likely to get severe pushback if you don't approach it from a position of know-it-all kind of arrogance or belittling the other side. So mutual respect and humility and being tentative in your claims. And there might be a lot of legitimate reasons why people wouldn't want to talk about it that are, completely legitimate. Not everybody has the time to do a complete in-depth study of the subject, so they may feel unqualified to speak on it, or they may be qualified but a lot of us as physicians, it's very common in medicine to have what's called the imposter syndrome, something that many experience at one time or another. We're qualified, but we know there's so much that we don't know. We might feel a little bit unqualified. So when that's a real thing, which it is, well, who's going to be the most vocal? And the ones who lack humility, the ones who are most confident, they're going to be the loudest voices. Whereas, humility is actually a good thing, but we should be skeptical.
You're taking me back to your first visit on my podcast. So for our listeners' benefit, if you didn't hear Dr. Willing the first time, he's written a book entitled Superbia, which is the Latin word for pride. And so Dr. Willing, in a 15-year project, was that 2-3 years ago, came out with Superbia. And what you're sharing with me are tenets based in that book. Those who probably know the least sometimes can be the most confident of what they think they know.
Yeah, but let me go on with what I was saying. There's this thing called the false consensus effect. It's a cognitive bias where people are generally inclined to think more people agree with them than actually do. That's kind of, you hear this when you see somebody writing for the New York Times that I don't know anybody who voted for Donald Trump. How could he possibly have gotten that many votes? We all live in our bubbles. But one of the best pushbacks, one of the best weapons against the false consensus effect is if one or two people are just willing to come up and speak. And not only does that push back against the false consensus effect, it also inspires courage among other people. Sometimes it takes one person with enough courage to speak up. Remember the famous quote from Martin Niemöller, first they came for the gypsies and I didn't speak up, and then they came for the disabled, and then they came for the Jews, and they came for me, and there was nobody left. In summary, not a very good quote. So there's that. But I would be very sympathetic because not everybody's in the same position. If you are in an academic setting, or if you are in this case where it's maybe very hostile, maybe there are some people who it is better just to remain silent, given it's a very individual decision, and not everybody faces the same amount of risk. I have complete impunity. I'm retired. Nobody can do anything to me. And there's a nationwide physician shortage, so if you're a doctor and they fire you, you're going to find another job. Now, I'm not blowing this off. If you're a physician couple and you spent 3 years finding the one place in the country where you could both practice, well, you're okay. You're in a different risk category than somebody who's near retirement. But there are a lot of aspects to that. And, I've been fired before, and it ended up being one of the best things that ever happened to me. So that's not necessarily something to fear. So there are a lot of angles to that, but I would encourage people to the extent that you're able and the extent that you're willing to invest in this, to speak up and just speak softly, gently, and with humility.
Yeah. Well,
I hope I've done that today, but I don't know.
Yeah.
I'll let other people do the judging.
I think that's a very appropriate way for us to finish up this conversation. Dr. Gene Rudd was just sharing with me a book that he's really been taking a deep dive. I can't remember the author's name, but The Sin of Certainty. The Sin of Certainty. Dr. Steve Willing, I'm very grateful. You continue to post on your own blog entitled The Soggy Spaniel. I believe that's the name. Yes. And look forward to future postings on the Soggy Spaniel and opportunities to interact with you. Thank you for taking the time to join us today on Faith in Healthcare, Transgenderism through the lens of neuroscience. God bless you.
Thanks, Mike. God bless you too.
As we've just heard from Dr. Steve Willing, neuroscience has a lot to say about questions of gender identity, from brain imaging studies that continue to affirm male and female differences, to the sobering evidence of how puberty blockers and cross-sex hormones, they can alter brain development and carry lasting harm. Dr. Willing reminded us that while culture often frames this issue ideologically, the science, it tells another story. And as Christian healthcare professionals, we must hold fast to truth while engaging with humility and compassion as well as courage. And remember, here on the podcast and throughout CMDA as an organization, you have a community that stands with you, friends. We're here to encourage you, to strengthen you, and support you as you navigate the moral and the ethical and the spiritual challenges of practicing healthcare today. So friends, if this episode encouraged you, would you share it with a colleague, a friend, or a student in healthcare? And be sure to follow the podcast on social media to stay connected. Your support helps us grow this community so that we can advocate for and equip healthcare professionals in all specialties to take Christ to the whole earth. If you've followed CMDA's The Point blog, you know that it's been a space for thoughtful, faith-driven reflections on medicine as well as meaning. Well, now we're excited to invite you to the next chapter, The Point of Medicine. It's a new forum where the conversation continues and goes even deeper, expanding from a traditional blog post to a vibrant forum of discussion. It's a place to engage with others who see medicine not just as a profession, but as a calling, one that honors God, as well as wrestling with real questions and seeks truth with humility and purpose. We sure would love for you to join us by going to cmda.org/point. Next week, I'm going to be joined by CMDA's Vice President of Advocacy and Bioethics, Dr. Brick Lance, as we take a global look at one of today's most pressing advocacy issues, that of abortion. Our guest is going to be Professor Amy Adamczyk of John Jay College. She is the author of a new book, Fetal Positions: Understanding Cross-National Public Opinion About Abortion. She draws on decades of sociological research and extensive global data. Dr. Adamczyk reveals why views on abortion, well, they differ so dramatically all around the world, as well as the surprising influence of religion, culture, and economics, and what Christian healthcare professionals we can learn from the contrast between the United States and China and other nations beyond. I want to thank you for listening to Faith in Healthcare, our weekly podcast from CMDA, where our mission remains the same by God's grace, bringing the hope and healing of Jesus Christ to the world through committed Christ followers in healthcare. That's what matters to CMDA, friends. May you recognize this week that the Lord is with you and that He is for you to do His good work. Thanks for listening, and we'll see you next time, Lord willing, on Faith in Healthcare.